So with that, I would like to introduce our next speaker, Dr. Kim Oosterhouse. And Dr. Oosterhouse is an assistant professor in the School of Nursing here at Loyola. And her research focuses on delirium in older adults. And she looks at prevention, early identification, and management of delirium to improve health outcomes. She's currently investigating the use of health informatics to retrospectively screen for patients with delirium from the electronic health record. And so with that, I'd like to welcome Kim.
So I am honored to be here today to present my journey on one method for using the electronic health record in my research. And thank you, Dr. Houston and Dr. Kostovic, for your amazing presentations. I feel like this falls right in line with one of the aspects of Dr. Houston's work from this morning. So I have no actual or potential conflicts of interest to disclose. And I'd like to first start with a definition of delirium to make sure that everybody really kind of has an idea of what this is, because it's very surprising that many people really do not know what delirium is and have a difficult time differentiating delirium from dementia. So as a DSM-5 psychiatric diagnosis, delirium is an acute and fluctuating change in mental status that's secondary to a medical cause. And it also involves inattention of that patient. It also has to have attributes of either confusion or disorganized thinking, or a change in level of consciousness, which include hypervigilance or somnolence, lethargy. Hyperactive delirium, there are three subtypes: hyperactive, hypoactive, and mixed delirium. The hyperactive form is more associated with that hypervigilance. And this is the type of patient that you may see that is acting out, shouting, may be agitated or aggressive, whereas the hypoactive delirium patient will be very somnolent, quiet, maybe just you may be thinking that they're sleeping as you go in and check them. They may be really groggy. And so you really kind of have to, get them to wake up and see, what is going on. Are they just sleepy because of a very not sleeping well overnight or a long day? But the hypoactive form, and of course, who do we think is going to get the most attention from the healthcare staff, is probably that hyperactive person, whereas the hypoactive, they're sleeping and they're not bothering anybody. But unfortunately, that hypoactive delirium patient has the worst outcomes, and they are the most ill, and it's the least recognized form of delirium. So the presence of delirium is most prevalent in older adults, though it can occur in all age groups. And the highest incidence of delirium does occur in acute care. It is known as a medical emergency. So there are a lot of negative health outcomes associated with inpatient delirium, and this includes injury, increased length of stay, increased discharge to long-term care, whereas a person may have been admitted from home, increased readmission rates as well. The patient may experience long-term functional decline, and there is an increase in mortality. So there are screening and diagnostic tools that exist, but there are barriers to their use. And some of my prior research has looked at critical care nurses' barriers and attitudes to screening patients for confusion or for delirium. And so some of these barriers include thinking about ageism can be a barrier, lack of time. Many times there are no protocols in place. Maybe the The facility has not adopted a standardized screening tool or diagnostic tool. And then the accuracy as well is an issue because the nurses or physicians need to be trained on how to use these screening and diagnostic tools. Another problem with a barrier is that you can diagnose or screen a patient, but then what do you do with that information? So not having a plan in place is another problem. Many of our intensive care units have adopted the confusion assessment method ICU or the CAM ICU to screen delirium as part of a delivery bundle, so a care delivery bundle. However, on the general medical surgical units, there has not been a delivery bundle that has been implemented or used, and there often is not a screening tool that is available universally. So in addition, the language that's associated with delirium is also confusing, and the urgency may not be communicated to the healthcare provider that this change has occurred. So for example, you may get in report that Mr. Smith was pleasantly confused. Well, that doesn't have the same urgency as saying Mr. Smith has a change in his level of consciousness. Okay, so there are different factors in our own communication of delirium that can be problematic. In research, our focus has turned more to identifying high-risk patients and preventing delirium because it can be prevented, but to prevent it, it first needs to be recognized. So why focus on early recognition of delirium? Well, not all precipitating factors of delirium can be prevented. So we know that maintaining mobility, providing our sensory supports like hearing aids, glasses, that sleep-wake cycles, supporting the sleep-wake cycles, eliminating drugs for inappropriate use for older adults, and other nursing interventions can decrease delirium risk, but there will still be incidences of delirium. So I'd like to tell you a story about Dick and Eleanor. So Dick and Elle lived in a senior residence, and Elle developed pneumonia and was admitted to a local hospital where she was treated and discharged to an intermediate care facility for rehabilitation. And Dick visited her every day, every morning. And one day I received a call from Dick, and he wanted me to come and see Elle right away because she had taken a turn for the worse. So when I arrived, Elle had her eyes closed and she appeared very peaceful. I greeted her with, "Hi," and immediately saw her eyebrows raise, though her eyes didn't open. So this was significant to me because she always had exclaimed, "Kim," her whole face lighting up in the happiest way whenever we were together. So I knew she was in there. As a critical care nurse, this was not the first time that I had experienced an older adult exhibiting an acute change in their mentation, that inattention, and in Elle's case, a change in level of consciousness. So we'll talk about them a little bit later. But the question, because many cases of delirium are missed, became, can we identify inpatient older adults with delirium from the electronic health record? Could delirium be picked up through machine learning using informatics? So based on a theoretical framework by Nelson, the informatics relation of data, information, knowledge, and wisdom, and automated systems, we use the framework beginning at the level of data, naming, collecting, and organizing. So Loyola has this phenomenal clinical research database, and it was developed and overseen by our Associate Vice President, Ron Price, and his team in strategy and innovation. So through June 2018, and actually currently, we have more than 3 million patients, so unique patients in this clinical research database. So these are their health records. It was initiated in January of 2007, and we have more than 884 million clinical documents. And this allows researchers to have access to structured data, semi-structured data, and unstructured data. So these are the three types of data that are captured by the electronic health record. The structured data we would know as our lab tests, vital signs, diagnosis codes, assessment checklists, drop-down lists, those types of things. The semi-structured data include information on our medications, procedures, and working diagnoses for patients. The unstructured data are found in those narrative notes. And in the narrative notes, this is where we supposedly can find approximately 80% of data within that electronic health record. And until recently, this huge, rich source of data has been relatively untapped. So Ron and his group had done Project ARIA, which was unlocking the clinical data pyramid. And as you can see in current traditional institutions, 20% of the data is being used, but they haven't tapped into that narrative data, which can be tapped into using natural language processing. And so our clinical research database and the team in strategic and innovation center has gone and mapped that 80% of our narrative notes. And so this natural language processing that they use and these efforts that our Loyola team did were recognized in the Journal of American Medical Informatics Association. So we are really on the forefront and cutting edge with this clinical research database. Well, now we have to veer off a little bit and talk about the Unified Medical Language System, Metathesaurus. And so the electronic health record was really developed for billing purposes. So many different billing systems are used, each having its own coding language or its own ontology. The United States National Library of Medicine certifies those various classification systems and dictionaries for approved use in our electronic health records within the United States. And the Unified Medical Language System, Metathesaurus, is a repository for dictionaries and classification systems of health-related and biomedical information. And it takes these independent taxonomies and links them by concept. So I'm going to give you a little bit of example here. So our medical vocabularies include things like our DSM-5 diagnostic codes, our International Classification of Disease 10th revision, so the ICD-10 codes, previously ICD-9 codes, RX norm, which is standard nomenclature for clinical drugs, and example nursing outcome codes, right? Do you remember learning NIC and NOC from school? Well, yes, we actually use it and have medical vocabulary taxonomy that is included in the UMLS related to nursing codes. There's also the MESH medical subject heading. So you can see all of these different ontologies. And so again, we're linking, UMLS is linking those standardized ontologies by health-related concepts. So using the term delirium as an example, the UMLS Metathesaurus links the 10th revision of the ICD to related code nursing outcome classification acute confusion. So ICD-10 delirium is linked to NOC, nursing outcome code confusion. Using natural language processing, clinical engine text analysis, and knowledge extraction system, or CTAKES, our medical and our IT team mapped all of the clinical research database documents using the UMLS system. So we have access to all of this NLP data. And currently, there are over 125 plus billion UMLS concept unique identifiers. So we're going to talk a little bit about these concept unique identifiers, the semantic type unique identifiers, and then the atom unique identifiers. So concept unique identifiers, and you can see I've pulled up the UMLS Terminology Services Metathesaurus browser. And in this area right here, you can see the concept of delirium. So in the UMLS, health-related and biomedical concepts such as delirium in the previous example are defined as concept unique identifiers, or CUIs. And CUIs are assigned a numeric code, which is preceded by a C, which you can see in that circle I showed you, or that elliptical I showed you. And the UMLS CUI code then for delirium is C0011206. And some of these concepts are synonymous terms with delirium, and others describe relationships to delirium. And there are multiple concept unique identifiers identified for delirium and the related terms in the UMLS. So this, it's showing right here, there's here's 1 through 25 of 298 results for concept unique identifiers for delirium. Well, also on that same page, you can see that there is a semantic type. And so what a semantic type is the category of that CUI. So the semantic type unique identifier, or TUIs, include categories such as mental or behavioral dysfunction, disease or syndrome, therapeutic or preventative procedure. And they also have a specific code. And so for delirium, you can see the semantic type is mental or behavioral dysfunction. And the code, it starts with a T for TUI, is 048. And then each concept unique identifier with its TUI, its semantic unique identifier, are made up of atoms, or atom unique identifiers. So these smaller parts are unique to the system or the dictionary that it originates from, and has an atom unique identifier that fits within that overarching concept. So delirium is our concept. We can see here that there are 189 corresponding atoms that make up that concept of delirium. So note, there is a vast difference in terminology here. So you may see acute delirium, you may see acute brain syndrome, you may see confusion, you also may see other things like sundowning. So these smaller parts are what make up that concept unique identifier overall. So knowing this, this is all new to me for informatics, so this is my journey, really. So knowing that we have these CUIs, but I don't have as many, we have the ability to use these CUIs. What we did was we wanted to come up with a question: can CUIs be used to identify inpatient older adults with delirium from that unstructured data in the electronic health record? So we ran a query on all adults that were 65 years and older who were inpatients for at least 2 days from the beginning of our CRDB, so that was January 2007, through the end of 2018. And we ended up with 51,000, or the total patients that were within that 65 years and older with the 2 days of inpatient stay were 51,830 unique patients. And then we queried the same for ICD-9 and 10 codes for generalized delirium. And so pulling out from that 51,829 unique patients, we got ICD-9 and 10 codes of delirium for 2,300 of those patients. Now we know that delirium is undercoded in medical billing, so through those ICD-9 and 10 codes. So we ran a query for general delirium CUIs with that same population, and our results came back at 20,938. So 10 times the number of CUIs came up than the number of ICD-9-10 codes. So this was very intriguing to us. We felt like, okay, we have enough data here to use. So this is just what our clinical research database looks like when you're doing a query. And so looking at this, you can see, again, it tells you how many unique patients and then patient encounters. So that one patient may have come back several times, so that those are encounters. And at any rate, we were looking for, okay, you can click on any, whatever define things you want to define. So we wanted all races, we wanted patients that were 65 and older, that were only inpatient, and we put our dates in. And so our first query was, again, using the ICD-9 and 10 codes for delirium. We inserted that. And then the second query was going to be putting in these CUIs. And so we selected our CUI codes and put that in, and that's how we obtained the information for our query. So we had all of these CUIs. Well, now we wanted to validate them. So were the concepts for delirium that are defined in the UMLS, were they valid? I mean, were they using the concept in the electronic health record when we pulled out a CUI for delirium? Was it being used correctly? So we received permission through the Loyola Institutional Review Board, and we pulled data. We had 3 raters that were going to validate our concept unique identifiers. I was the PI, and then 2 research assistants. And our research assistants were critical care nurses that had worked with older adults that had experienced delirium in the past. And they were trained on delirium identification with the ChartDel, which is an instrument that's used for chart abstraction for delirium. We chose 150 random unique patient narrative notes, and we trained by coding 100 notes for accurate CUI use. So was the context in which the concept unique identifier accurate, not if it confirmed delirium. And we also looked at inaccurate CUI use and indeterminate CUI use. So upon completion, we discussed our disagreements, and then we came to consensus on our coding. Now, inaccurate CUI use would be something like, for example, maybe it said the patient was confused about their plan of care. Well, that confused was not being used accurately as that CUI. So our results, we had 98% agreement between 3 coders. 98% of the concept unique identifiers for delirium were valid. 30% of those concept unique identifiers were temporal in nature. And so what that means is that it might have been that we have, it might have said that the confusion was stabilized, for example. Okay, well, that's temporal in nature. That means somewhere along the line, they must have had confusion that was new, and now it's better, or improved from where it was before. So we had to think about the temporal sequence of that. And then 2% of our concept unique identifiers were inaccurate representations. So we had 2 important insights from this. The first was that while it appeared that anesthesia documented frequently on delirium, the reality was that a standardized template was used to describe possible complications of anesthesia in patients postoperatively. So that included the possibility of developing delirium postoperatively. And second, nursing while using the NANDA diagnosis of confusion at some point in that hospitalization. Again, this is where we got that stabilized confusion without defining the meaning of stabilized. So did that mean they were no longer confused? Did it mean that now they were lethargic? So rather than negating that concept unique identifier, we interpreted it as temporal in change, and it helped us identify looking at that fluctuating nature of delirium. And so in conclusion, we used CUIs for delirium, and it can be an important filter for retrospectively identifying older adults with delirium. We know that a single narrative note containing a concept unique identifier for delirium may not provide definitive information. We need more, and we need more before and after. And then sequential temporal CUI notes may identify that fluctuating mental status. So this was our preliminary work. Well, back to Dick and Elle. So to continue, when the rounding physician came in to see Elle that morning, I advocated for her. And Elle and Dick were my grandparents. So as it turned out, I had asked the physician, has she been checked for an infection? Has she had her, has she been looked at for electrolyte and volume status? And as it turned out, she was transferred back to the hospital where she was diagnosed with a urinary tract infection. They started IVs and they provided IV fluids and IV antibiotics. And within 24 hours, she was her bright, cheery self. So my grandmother turned 95 in December. She survived COVID. She reads historical biographies. She thrives on chocolate and her great-grandchildren. So she has 13 and 3 on the way. And she can't wait to continue playing bridge on Mondays with her friends and my mother. And she got to see her Cubs win the World Series. My grandfather passed away 10 years ago. So grandma's doing just great. So our next steps are, we received a grant from the Network for Investigating Delirium, Unifying Scientists, and we are currently looking at 5,000 notes, so 1,000 electronic health records, and we're determining the positive and negative predictive values for patient delirium from this unstructured data. And then later, next steps will be adding structured data for modeling and for the development of a computable phenotype for delirium. And then long-term, we hope to develop an early warning system or a delirium clinical decision support in the electronic health record for nurses in order to help collaborate with physicians. But as we said before, some of that can be overstimulating, and we need to make sure that there's a plan in place rather than just providing that early warning. Now what do we do with that from there on out? So our theoretical framework where we're hoping to go to will be between knowledge interpreting, integrating, understanding, and decision support. Thank you so much. And if you have any questions, please feel free to ask, and please feel free to email me. I know it's a lot of information in a short amount of time.
Thanks so much, Kim. That was a wonderful presentation. Are there any questions, Dr. Connor?
Yes, but first of all, I do want to just thank you for the presentation. I think at the heart of all of this, and you're right, it's a lot of information, it's a lot of new information, and we can get lost in all this data. But thank you for bringing back Dick and Elle, and really that's the heart of all of this work. And I know your passion and compassion for the older adults, and I know that that's really what this is all about. So so I wanted to acknowledge that. The question that someone had posed, I'm not sure if this is something you can ask, is when doing these database studies, is it in your opinion, and now that you have worked with CUIs, is it better to use CUIs instead of ICD codes?
That's a great question. So in my work, it is, I'm using both, but I am focusing on the concept unique identifiers because it is known from previous research that delirium is undercoded using ICD-9 and ICD-10 codes. So this was, we would have missed a lot of patients that potentially had delirium if we had only used those ICD-9 and 10 codes. And in my current research, so I guess a little preview is I am finding quite a few patients that are actually, they will even say, a physician will say that they have delirium, however, they had not been coded for that, or the nurse will indicate the confusion and the fluctuating status, all of the components of a definitive diagnosis, though we're not diagnosing it, we're just looking for those components, but they are there. And again, they did not have an ICD-9 or 10 code. So I think it really depends on what the concept is that you're looking for or what the diagnosis is that you're looking for. Thanks.
Thank you. So now we know who to go to for when we have questions about this.
Okay. Thank you again.